Hello everyone, I'm Dr. Monica. Today in this video, we'll be talking about acute necrotizing ulcerative gingivitis. So let's begin. So let's understand what is ANUG. It's rapidly destructive, non-communicable microbial disease of the gingiva caused by an impaired immune response. ANUG usually starts suddenly with inflammation and pain in the gums. You can see in the diagram that there are punched out crater-like lesions, especially on the papillary gingiva, and it can extend further into the marginal gingiva, attached gingiva, and oral mucosa if left untreated. ANUG is also known as Vincent's disease since in the 19th century a French physician called Vincent first described this condition. The other term is trench mouth, since during the World War I, the soldiers who were living with high stress, poor nutrition, and inadequate oral hygiene also developed this kind of condition. Other names for ANUG include fusospirochetal gingivitis, acute ulcerative gingivitis, necrotizing gingivitis. Pain is considered to be the hallmark symptom of NUG, with patients often reporting constant, radiating, and gnawing discomfort. Other common signs include a foul and fetid odor, a metallic taste in the mouth, and increased or pasty saliva production. So, why is this disease important clinically? Though ANUG has a low prevalence rate, if it is left untreated, it can rapidly destroy the tissues and further cause necrotizing ulcerative periodontitis, in which, along with the gingiva, the alveolar bone is affected. Later on, it can progress to cancrum oris, or known as noma. In this, even gums, cheeks, and lips are involved, and it is a fatal condition. So let's understand the etiology of ANUG. It is a bacterial infection, mainly having gram-negative bacteria. Predominantly, we can see spirochetes and fusiform bacillus, and bacteroids, intermediates, and fusiform bacterium species are most commonly associated with ANUG. Coming to pathophysiology, we can see we have various predisposing factors which causes ANUG, which include the psychological stress, poor diet, poor oral hygiene, any pre-existing gingivitis, lack of sleep, consumption of tobacco, alcohol, and immunoinflammatory infections like HIV. So all these factors, they impair the host immune response, and it can increase the bacterial pathogenicity, so it can lead to development of ANUG. Coming to histopathology, on gram staining we can see four distinct zones. First zone is the bacterial zone, which is the most superficial layer. In this, fibrous mesh is made up of epithelial cells, leukocytes, spirochetes, fusiform bacteria, and rods. Next zone is the neutrophil rich zone. In this, we can see increased number of leukocytes, spirochetes, and the bacterial cells. The next layer will be a necrotic zone. In this, disintegrated cells will be seen along with spirochetes and fusiform bacteria. Now the deepest layer is the spirochetal infiltration zone. In this, only spirochetes are seen which infiltrate the tissue with no other organism species. Coming to diagnosis, ANUG can be diagnosed by using various signs and symptoms, including mouth pain, which is rapid in onset, bleeding gingiva, ulceration and necrosis of the interdental papilla, fetid odor of breath, pseudomembrane formation on gingiva, signs like malaise and lymphadenopathy. Talking about differential diagnosis, the various diseases which show similar symptoms to ANUG include acute herpetic gingivostomatitis, streptococcal gingivitis, candidiasis, infectious mononucleosis, desquamative gingivitis, multiforme erythema, and pemphigus vulgaris. Now let's talk about the management or treatment of this condition. ANUG is treated in different phases. First one is treatment of acute phase. Second one is the treatment of pre-existing condition. Then treatment of disease sequelae. and last is supportive or maintenance phase. So let's begin with the treatment of acute phase. In this, the aim is to relieve patient's discomfort. Second is to stop further tissue destruction. This is the first visit treatment provided to the patient, in which superficial ultrasonic debridement is done. Oxygen therapy localized at necrotic lesion, that is the papillary gingiva, using 0.12% chlorhexidine gluconate mouthwash is given. Patients presenting with symptoms like fever, vomiting, malaise, etc., they are given systemic antimicrobials. The main choice of antimicrobial here is metronidazole 250 mg 3 times for 7 days or amoxicillin 500 mg orally every 6 hours for 10 days. The instructions given to the patient on the first visit include rinsing every 2 hours a glass full of equal mixture of warm water and 3% hydrogen peroxide or twice daily with 0.12% chlorhexidine. Patient is asked to take adequate rest, confine toothbrushing to remove the soft debris using ultra-soft brush and bland dentifrice. Patient is also asked to avoid consumption of alcohol and tobacco products and to report back in 1 to 2 days. On second visit, which is 1 to 2 days after the first visit, patient is evaluated for amelioration of signs and symptoms. If any calculus is visible, it is gently removed and same instructions as given in the first visit is continued. Now talking about the treatment of pre-existing condition, this is done on the third visit, that is 5 days after second visit. In this visit, scaling and root planing is done. Predisposing factors such as stress, poor oral hygiene, disturbed sleep, smoking are addressed. Patient is asked to discontinue hydrogen peroxide mouthwash but continue with the chlorhexidine mouthwash. Talking about the treatment of disease sequelae, gingivectomy or gingivoplasty are performed to treat any superficial craters present on the gingival surface. The last treatment phase is the supportive or maintenance phase. In this, patient is asked to comply with oral hygiene practices and control any predisposing factors.
Please like and subscribe to this channel. Thank you.